Hi, I'm JP Begley, a sports medicine surgeon at Central Vermont Medical Center. I'm here to talk to you today about hip impingement and hip arthroscopy. I completed my medical training at Johns Hopkins and followed this with orthopedic residency at NYU's Hospital for Joint Diseases in New York City. Following residency, I spent an additional year training in sports medicine at the Stedman Clinic in Vail, Colorado, where I learned arthroscopic hip techniques which allow me today to help patients with hip impingement and labral tears. Historically, hip impingement and labral tears would be diagnosed as hip strains or adductor strains. We've started to realize that hip impingement and labral tears may predispose to pain and even to the development of arthritis in the future for patients. In the past, injuries such as these may eventually require open procedures, which added additional time to recover and bigger incisions for patients. Presently, we're able to achieve treatment of a lot of these issues with an arthroscopic technique involving minimally invasive surgery to treat patients' underlying bone impingement as well as labral tears. Arthroscopic hip surgery is still relatively new to the field of orthopedics, and I'm one of the providers in New England who is routinely performing this procedure. Hip arthroscopy is an outpatient procedure that involves 2 or 3 minimally invasive incisions and specialized equipment, allowing us to take off bone spurs which may be contributing to hip impingement, as well as effectively treat labral tears which may be contributing to patients' continued hip pain. Signs and symptoms of hip impingement include functionally limiting anterior groin pain and pain that is worse with activities. Oftentimes patients will remark that although they can perform the activities they enjoy, they can't perform them up to their expected level due to the discomfort. Patients who may be indicated for this procedure are usually active individuals with minimal hip arthritis who have had symptoms that have persisted despite prolonged non-operative treatment, which usually includes physical therapy and activity modification. However, physical therapy aimed at core strengthening and strengthening of the affected regions may not be successful over a long period of time in relieving their symptoms. In this situation, these patients may have underlying hip pathology that's contributing to impingement and may be a candidate for evaluation from a sports medicine surgeon trained in hip arthroscopy such as myself. In pincer type impingement, there is extra bony coverage on the socket side of the hip. When the hip moves up into positions of risk, such as flexion and internal rotation, this extra bone leads to impingement. Impingement is when the bone pinches the labrum, which is a structure that forms a suction seal around the hip. Over time, this may predispose to bruising as well as tearing of the labrum. The labrum has pain receptors, and in some patients, this leads to clinically significant impingement and pain. The extra bone on the socket side acts as more than just a doorstop. It also changes the dynamics of hip motion such that there is increased stress on the cartilage throughout the hip, not just in the region of the labral tear. In cam type impingement, there is extra bone located at the region where the head of the femur meets the femoral neck. In positions such as internal rotation and flexion, this extra bone contacts the socket and may lead to damage to the labrum in this position, including tears of the labrum and a loss of the suction seal that the labrum contributes to the hip. In addition to labral pathology, the extra bone on the femur can damage cartilage in the region of the labral tear and predispose patients to early degenerative changes within the hip. If you have a patient who's not improving with non-operative measures and physical therapy, and you think that they may have signs of underlying impingement, feel free to contact us at cvmc.org/ortho for more information and a possible consultation.